In healthcare, when someone is sick, they're at their worst. And when I say at their worst, they're not able to think straight, they're overwhelmed, particularly if they're really alone. So you have to build systems that are really easy, really straightforward, really clear. And sometimes a lot of people have low literacy. In the UK, the average reading age in the UK is a 14-year-old. And that's not me or you when we were 14, because we were probably very academic. When we were 14, we probably read at the age of an 18-year-old. Most people at the age of 14 read the level we did when we were like 10. So do you think about having a system that a 10-year-old us can read? So when it comes to using them for therapy, weirdly, I kind of think it's good.
Is it? And not because, and is it because they lack empathy? Or you expect that the robot or ChatGPT lacks the empathy and they will logically answer you?
Different reason. So if I talk about Rwanda later, so in Rwanda, there was much less, there were fewer doctors available. So if I was going to roll out some sort of chatbot at doctor, if the user didn't use the chatbot, what would they use instead? Potentially nothing. So in that context, something's better than nothing. Is it perfect? No. Should it be a real human? Yes. If you think about therapy, so I need to speak to someone, I'm having depression, stress, I've got a problem with my mother-in-law, who knows? We were in a low technology environment. Most people didn't have smartphones. So how do you engage in a chatbot if you don't have a smartphone? If you have one of these old Nokia phones with 10 spaces for SMS, anyone who's below the age of 35 has no idea what I'm talking about. But it used to be, you could only have 10 text messages in your phone. Just think about that. So if you're trying to do a chatbot on a phone and you don't have an app, it doesn't work. So what we did there was, we got a patient who felt like they were sick to call up a call center. The call center was staffed by people who would use the chatbot on the patient's behalf and ask questions and type in the answers. So it was like a telephone service, but the thing that the receptionist user was using was our chatbot. They would ask the questions and they would give the feedback. So that was a kind of weird way of getting over that context of low technology.
Welcome to the Priceless Conversation, the podcast where we explore and navigate the art and science of product management, AI, automation, and pricing. We do this with a mix of wit, wisdom, and dashboard war-related stories. Hi all, I'm Satya, a scientist who turned into product management, a manager, and then navigated the world of AI. So I still connect a lot of dots and do research here and there, and use a lot of data.
Thanks, Satya. And I'm Amit. I work in product and pricing, helping teams decide what to build and how to charge for it. I ask the hard questions and share lessons from the field. Glad you're tuning in today. Our guest today is Randeep Sidhu, an health tech powerhouse who's been shaping high-impact systems under the most intense conditions. He led the rebuild of the NHS COVID-19 app in just 6 weeks, influencing tech that saved over 10,000 lives and slashed hospital cases by half. So, to everyone who's listening today, welcome, Randeep Sidhu.
Hi, Randeep.
Hey, thanks for having me on the show. Yes, that was a very warm intro. It feels kind of unwarranted, but thank you. Yes.
So let's dive in, Randeep. I want to ask with the question that's more pressing in the healthcare world as well, is there are a lot of products in the AI and healthcare space right now.
Mm-hmm.
And you have been working on something that's the most crucial and that was very critical during the COVID times. How did you measure the value of the healthcare app? In general, usually products are measured by the impact that they have created, either by revenue, either by number of users, but how does it differ for a healthcare app?
Great question. So maybe I'll introduce my background, which then relates to how this works. So my background is I am not a doctor. I've never really worked in healthcare. My degree was evolutionary biology, which was super interesting and I thought was completely irrelevant to the rest of the world. And in evolutionary biology, it's going to be a roundabout answer to this question, but in evolutionary biology, you measure how animals are going to be successful. And you can measure that in hundreds of different ways. And so you kind of get used to just being non-linear in how you think. So I went from doing that as a degree, doing a lot of work in the charity space, and then becoming a strategy consultant where you did lots of business, kind of solving business cases. So I fell into product by doing product innovation at a strategy consultancy. And my first product wasn't actually in healthcare, it was in gaming. So my route was evolutionary biology, charity work, being a teacher and setting up these startups, then working in kind of digital consultancy, strategy consultancy, until I kind of fell into product management in a gaming company and then pivot into healthcare. So my route is so non-traditional, but basically everyone's route in product management is non-traditional. So if I'd become a doctor or someone from the system, I think what I'd measure would be very different. Because doctors, medics, rightly so, they're meant to save lives. And so their worlds are very regimented. So if you're a doctor, you measure oxygen saturation, that you're trained to be very specific about what you measure. And getting people with a medical background into health tech and AI is good, but it can also limit how they think about having impact. It's much more direct. Does this reduce oxygen saturation or increase it? If it increases it, do it. And so sometimes metrics in healthcare are very X makes Y happen. And that's good. But sometimes if you think about evolutionary biology, why does a praying mantis female eat the male during sex? That happens. It's evolutionary advantageous. But the steps to explain that aren't X equals Y. It's X equals A, B, C, D, E, and then leads to Y. So sometimes a non-linear path can be helpful. So that's kind of my way of thinking about the world. So how do healthcare apps measure value? So the most simple, if it depends on the healthcare app, but if you say, I was working at a company called Babylon Health. Babylon Health was a healthcare unicorn in the UK, and it was the largest GP service, e.g. primary care service. For non-English listeners, that would be if you get sick and you have a cold, you call up a doctor, that service. So we were the largest public, e.g. National Health Service GP with tens of thousands of patients, and the largest private, which meant that we did lots of front facing. When someone was sick, they had to call up and use our service. And in that system, what was the metrics we cared about? So in a primary care service, there's an echo, Amit. In a primary care service, you want to be able to get to a doctor quickly, because if you get to speak to a doctor, that means anything that's wrong with you can be treated quickly. The difference is when you think about other healthcare services, like if you're in insurance, if you're a diabetes management app, if you're like I am now on the board of the NHS, other metrics are more important. So how quickly you see a doctor is the medical metric. It's like, well, if this person is sick and they see a doctor, that means that they're going to be okay. But for me, with my non-linear thinking, I'd also want to measure things like time to resolution. Just because you've spoken to a doctor, how quickly before they are finished? Did they get the medicine? Did they take the medicine? Like if you speak to a doctor today and then it takes 2 weeks for you to get the medicine, that feels like something's not worked. What happened in those 2 weeks in between? It took 2 weeks for you to get okay. Maybe if you didn't need medicine and you have to call back again, the system might look at that as 2 doctor appointments, but I would say you spoke to a doctor, 2 weeks later you spoke to another doctor, it wasn't fixed. So for me, the metric that you should use to measure value is a patient healthier, is the patient happier? And that's hard to measure sometimes. And because of that, people don't always measure it. They're like, well, I don't know when the person's better. So I'll just measure what I can measure, which is how quickly did they, when they click the button, get to speak to a doctor? So the danger in healthcare is we measure what's easy to measure, not what is the biggest component for the end user. So if you put yourself in the space of being a patient, if I speak to a doctor, yes, it's important how quickly I speak to them. But when I speak to them, I want to make sure that they get me better, or they listen to my problems, or they understand what's wrong with me. If they just speak to me going, no, I'm going to give you paracetamol, get off the phone, do I feel like I've been looked after? So sorry, that's a kind of big, long answer to your simple question.
I think it's very important to know that not all the time it's the quick incentives that you can measure, but sometimes it's the loop is different. What stops people from not really measuring how many people have used it?
So now with AI, it's quite interesting. People are more aware of it. There's this term closing the loop or getting reinforcement learning. So for example, simple example, Satya, I'm your doctor. You call me, you go, I've got something wrong with me. I'm like, okay, great. Just go home and sit down and, I'm better now. How do I know as a system that you got better? I don't have that positive reinforcement. How do I know you didn't get better? You call me again. So sometimes the signals I get don't tell me what's important for you. I have no way of knowing if my advice was helpful or if it wasn't helpful. Therefore, because it's human and it's soft, I can't measure that. And instead of making effort to work out how to measure that, I just go, oh, it's too complex. What I'm going to measure is what buttons in my app I can just put, mixed panel triggers in it. So because the system is set up in a way, we measure what's easy to measure. And we sometimes try and use that as a proxy for what's really happening in the system. So what it takes more effort to do is build in measurement in places that's more important. So maybe we would have a push notification in the app going, did you get better, yes or no?
Yeah.
That's a measure.
Yes.
Do people do that? No. Oh, because marketing say it's annoying. It's not how I was like, yeah, it's annoying, but it's annoying in a good way. Because if you didn't get better and you said no, maybe we can give a different path to that user to say, oh, we can do an express call with the doctor, and it's a more senior doctor, or they're going to pay more attention to you. Instead of thinking about the user, we make the user fit into a system that we can measure. And if the measurements are good, we think the system's good. If the measurements are bad, we think the system's bad. But the measurement doesn't always track to what the patient is feeling. And that's the same in lots of systems. The only things that get measured are the things that are easy to measure, and we optimize around that.
These are all the invisible aspects of a product. It's so much out of system that a patient has to come back and give you the feedback and then go out of the system. And there are many such products which have value which is hidden. It's not usually in the buttons. It's not usually how you measure the scroll or the time you're on an app or a website. But then imagine there is such a product. Okay, how do you measure the value of an invisible product? I want to call it as an invisible
Not invisible.
product.
That's the point. It's invisible to the AI and the data systems because they can't measure it. When I described to you, Satya, what happened, I didn't blow your mind. It's not like, oh my God, patients don't get better. That's not a radical idea. It's not invisible. It's hard to measure. That's the difference. So if we take our heads out of the products we build and out of technology and go, why the jobs to be done concept? Why is this user using our service?
Yes.
When they open Netflix, why are we opening Netflix? Because we want to get distracted. We want to watch something engaging. So what metrics can we measure? But maybe we have some other proxies. Maybe we don't build it in the app. Maybe we have to do surveys and something outside of the app. So my assertion is many things aren't invisible. They're hard to measure. So to your question about the value of healthcare, it's really simple. Healthcare is there to make you feel reassured in case you're worried about something being wrong with you, to make you better if something is wrong with you, and to give you confidence that as you're living your life, you're not paranoid about the future. When you hit 80 and you need a hip replacement, healthcare, you believe, will be there to look after you. You're not just going to be left on the side of the road to die. So it's that simple. And yeah, getting there is hard. But if you've got, I'm sorry, because I'm talking in generics, but
that's okay.
If there's some examples, feel free to give me a specific example. I can talk through that in healthcare, if that helps.
Instead of healthcare, or like within healthcare also, we have chatbots that are now talking to us about our symptoms.
Yes.
So let's talk about that as a use case.
Okay. So Babylon. So when I joined Babylon many years ago, I was product director of AI, and Babylon, their vision was to build. It was a video calling system with a doctor. So a bit like we're on a video call, which is not revolutionary, but back then felt very revolutionary because doctors say X equals Y. And the medical community was like, oh my God, if you do video calls with a patient, people are going to die. Why? I mean, honestly, if it was a joke, it was that ridiculous, because they're like, well, when a patient walks in, depending on how they walk and how they move, and sometimes the last minute when they're leaving the room is when they tell you what's really wrong. I was like, okay, I get that, but lots of people can just speak to a doctor. So the medical community really resisted this video calling concept. COVID happened, everyone accepted it. So now it's just established. But when we first were at Babylon, it was really hard. And what Babylon were also doing is building a chatbot. The idea of this chatbot was it would do a medical screen before you spoke to a doctor. And the vision in the end was to have a chatbot that could replace a doctor, replaced by, if you just wanted to ask what's going on, you could talk to it and it would give you some information. So I've been in chatbots for like 10, 15 years now. So I can ask you to be more specific. So I can talk about the metrics that are important or the psychology of using a chatbot in medics. What's more helpful, do you think?
I think psychology part is more interesting for me. Amit, how about you?
Yes, the last time I spoke to Randeep, it was about anthropology. Yeah, I would like to talk a little bit about
Okay, so apologies for the listeners and the viewers who are like, what's this idiot going on about? But yeah, it's really strange. So you know the term uncanny valley. Uncanny valley is when you look at a CGI robot and you're like, it's a cartoon, it's a cartoon, it's fun, it's fun, it's fun. And then suddenly it flips into being almost human. So your brain switches from, oh, this is a stupid cartoon or this is a robot to this is human. And then when you switch your perspective to looking at it like it's a human, it's a really shit human. Whereas if it's a cartoon or a robot, it's fine because it's not meant to be human. The same thing can happen with a chatbot. So we played a lot with what is this chatbot? So it can open and it can, is it Dr. Sidhu? Is it pretending to be a human? Or is it just, I'm a robot, I'm not pretending to be human? And so we realized that it was better for it to be a robot because humans have empathy, robots don't. If a robot doesn't have empathy, you're kind of okay with that because you know it's like you're so used to Googling information. It's sort of like, oh, that's not meant to be caring. If you
Yes.
think it's a fake human, and I said something like, oh, my mother passed away yesterday, which is why I'm calling, I'm very stressed. And you went, I haven't got an appointment for you. You would feel hurt by that because that
Yes.
little bit of humanity is missing. And what you want from medical practitioners isn't just medical accuracy, it's humanity. You want to feel seen. So what we realized early on was it has to be a robot. And it forgave us lots of problems if it was a robot because people went, oh, the robot missed that piece of information. It's not human. It missed something. But when it comes to the psychology of speaking to a robot, it becomes very interesting. So let's say sexual health issues, embarrassing rashes and scratches, questions you're embarrassed to speak about.
Yes.
Yeah.
When you looked at the percentage of chatbot questions that were in those sensitive areas, they were far higher. When you looked at the populations that we helped, it was younger people, sometimes those who were a little bit poorer because they didn't have natural access to an expert and they felt more comfortable speaking to someone that wasn't going to judge them. So what we realized was making it a robot was beneficial both to the users and to the system. So when they asked these difficult questions, a robot could reassure them or give them information, which meant they felt more comfortable than speaking to a real doctor about it when relevant. So the psychology of how you engage with AI is quite interesting, which is where ChatGPT is like a friend that lies to
Yes.
you. We wanted to be a robot that's clear when we don't understand.
I think you also touch upon a point of therapy because now with ChatGPT, and there's a study that has been released by HBR, I think, that said increasingly people are using ChatGPT or Gen AI tools as a therapy or as a therapy partner. Of course, it can hallucinate quite a lot, but then it is relieving for quite a few folks.
In fact, I was speaking with a few product managers and they used ChatGPT to look at their career roadmap and see whether they took all the right steps or whether if they would have chosen some other path where they would have landed. So yes, these are interesting use cases.
I think, honestly, I am a big proponent of AI and ChatGPT. They're built on different models. The models I was building the previous chatbots on were some Bayesian inference, which, long story short, is like really complex way of asking, doing weightings, and you've got to literally screw every screw, and it's really complex, and you forget a screw and it all falls apart. Like, for example, in the chatbot at Babylon, it would do questions like, it would ask, say me and you, Satya, the same question. Then it would get to the end and go, you've got pain in your stomach, Satya, you've got a fever. Do your testicles hurt? And you're like, we forgot to put the screw saying women's bodies and men's. We just forgot that bit. Okay. And think about this psychologically. If a doctor asks that, you would never speak to them again because you're like, you are an absolute idiot.
Absolutely.
If a robot did it, you're like, so, it's really hard. The modern LLMs, you just throw information at them and it makes a model. So when it comes to using them for therapy, weirdly, I kind of think it's good.
Is it? And not because, and is it because they lack empathy? Or you expect that the robot or ChatGPT lacks the empathy and they will logically answer you?
Different reason. So if I talk about Rwanda later, so in Rwanda, there was much less, there were fewer doctors available. So if I was going to roll out some sort of chatbot at doctor, if the user didn't use the chatbot, what would they use instead? Potentially nothing. So in that context, something's better than nothing. Is it perfect? No. Should it be a real human? Yes. If you think about therapy, so I need to speak to someone, I'm having depression, stress, I've got a problem with my mother-in-law, who knows?
So I want to take Sorry, please go ahead.
No, I was going to say that in the context of therapy, there's so many people vibe coding, e.g., just creating a chatbot by, using ChatGPT to create an. But what do they need? They need to be heard, they need to be understood, and they need some chance to reflect. Let's not forget there is a whole school of therapy which I don't know if it's Freudian or one of the others, where literally you talk to a human and they sit there and nod and they say nothing. If you
How
talk to a person who doesn't respond to you, how different is that from a chatbot, which may or may not respond to you? So the context for me that really important is having an always at hand person that you can just be like, oh my God, I had an argument with my friend or colleague at work. What happened? You describe it, and then they can say, reflect. Do you think you might have been aggressive or not aggressive? So engaging with someone to break down your thinking, if they're a therapist or not a therapist, is good. And if the alternative is not speaking to anyone, it's good. But if I had it every day and I was in a really stressful position and I could speak to it 15 times a day, at the end of a week, I could say, summarize all my interactions, make it in an email, send it to my therapist. Next week, I'm going to speak to a human. They're going to have a summary and a diary of all the things that happened. And that summary might help that real therapist go, maybe you need to talk about your mother more. Let's work out what's going on. So for me, it's a thing that you can use immediately, and it can summarize and create a diary which can be used for real practitioners if you have one. And if you don't have one, of course, there's a benefit there.
that's wonderful and absolutely one of the use cases AI can do, and we all can do. Randeep, you talked about a little bit about Rwanda and
Yes.
your experiences there, and I've you also spoke that you had a non-linear path, starting from gaming to consulting to product management. You also had a different path in terms of moving in different geographies,
Yeah.
Africa, Canada, UK. How have these diverse cultural contexts influenced your approach to products, the strategy, the development?
Okay, so for the context of the audience, so when I was at Babylon, this healthcare company was in the UK, the biggest public NHS, the biggest private. It had operations in Canada. It had operations in Rwanda, where I built and kind of helped to build this healthcare system in Rwanda, and they had pilots in America. After Babylon, I then worked at a company called Reliance, where I was chief product officer. They were based in Nigeria, and they were a low income focused healthcare insurer who was building healthcare kind of insurance models in Nigeria and expanding to other emerging markets. And so we expanded into Egypt, and they will then expand into other markets across Africa and Asia. So the difference is less than you think in terms of user design. The reason being, in healthcare, when someone is sick, they're at their worst. And when I say at their worst, they're not able to think straight, they're overwhelmed, particularly if they're really alone. So you have to build systems that are really easy, really straightforward, really clear. And sometimes a lot of people have low literacy in the UK. The average reading age in the UK is a 14-year-old. And that's not me or you when we were 14, because we were probably very academic. When we were 14, we probably read at the age of an 18-year-old. Most people at the age of 14 read the level we did when we were like 10. So do you think about having a system that a 10-year-old us can read? So how different is that to taking that basic system that has to help be straightforward in other markets? The basic app design is the same. The difference is the context you operate in. So for example, in Rwanda, you always have to make a judgment in healthcare. It's about do no harm. So if I'm building a system, if I give it to the user, will this make it more dangerous for them long term, or will it make it safer? So in the context of a chatbot that would advise you to speak to a doctor, you might go, oh, in the UK, if someone keeps using this, they're not going to call their doctor. They might get the wrong advice. They might die. Small risk. In Rwanda, there might be different, because in the Rwandan healthcare context, most people, I want to say 40%, I might be wrong, live in below the poverty line. So if they want to go to a doctor, what happens is they take one day not working to go to the doctor's surgery, and they wait for the whole day, which means that's one day they didn't earn money, which means that's one day they don't feed themselves and their family, because they earn money, they use it to buy food freely immediately, or something like that. So the risk of going to a doctor is higher in Rwanda because you suffer a huge penalty. In the UK, I have a half an hour appointment, I go back, my work wasn't impacted. However, those who are very, very poor in the UK have a similar situation. If they have to go to a doctor, they might lose half a day's wages. So the reality is in Rwanda, we need to create reassurance. So this chatbot is super helpful because it means that people who might be really sick and should see a doctor get told, I think it's worth the risk for you to go to see a healthcare. This seems more serious than not. And sometimes there's other added benefits in systems like that. So what can happen is there can be other benefits.
Yes.
I'm going to pause there. I am giving very long answers. Should I give shorter answers so you can ask more questions, or am I okay as I am? Because I realize I talk for like 4 minutes and maybe you want to give me more to and fro.
I think it's good. It's good because the reason we don't interfere also is because we get as many points, and then if you have any follow-up questions, then we ask you as well. So
okay, that's right.
Cool.
So Randeep, you notice that we also create shorts,
Yes.
and these long answers help us to create those bites of videos. So please go ahead. Yeah.
Okay. So sorry, Amit, you asked a question.
Well, again, so just for the context of our viewers and for myself as well, we spoke about the cultural context of building apps in Rwanda, UK, Canada. You also did US, and you were talking about how it is important to see a doctor and the financial repercussions in low-income groups, because that means you spend almost a day's wages. What are the other cultural observations you saw, which our users might not know about?
So I'm aware I'm talking very much about healthcare. So it's kind of a weird context, but obviously there's other contexts as well. So if we think, I'm just going to talk about healthcare, but this applies to other areas. So in Rwanda, what was interesting is using a chatbot to try and engage, or a version of a chatbot that could help a user understand if they needed to speak to a doctor. So they would give up a day's wages. We were in a low technology environment. Most people didn't have smartphones. So how do you engage in a chatbot if you don't have a smartphone? If you have one of those old Nokia phones with 10 spaces for SMS, anyone who's below the age of 35 has no idea what I'm talking about. But it used to be, you could only have 10 text messages in your phone. Just think about that. So if you're trying to do a chatbot on a phone and you don't have an app, it doesn't work. So what we did there was we got a patient who felt like they were sick to call up a call center. The call center was staffed by people who would use the chatbot on the patient's behalf and ask questions and type in the answers. So it was like a telephone service, but the thing that the receptionist user was using was our chatbot. They would ask the questions and they would give the feedback. So that was a kind of weird way of getting over that context of low technology. But what we've also realized is the literal cultural differences were very different. So in Rwanda, people were less comfortable speaking to authority figures. So when they spoke to a doctor, they felt very nervous and they could feel very small. And they would sometimes not feel like confidence in talking about what was wrong with them. A random side effect of a pilot we did. So what we did was we rolled this AI out into medical context. We thought, we're going to get patients to, get a subset of patients to get them to try the AI to see if it helps. Because our vision was, instead of calling up on a call center, maybe if the patient turned up to a doctor's surgery or hospital, there'd be a little panel and they could talk into it or write into it and it would ask all the questions. It might take 15 minutes, but then they would have given their medical history. So when they then see the doctor would have already known the answers to lots of questions. So they could say, oh, you said you've got pain in your knees. Talk to me about that. Oh, but do you also have a fever? Maybe you've got meningitis. So it made it easier for the doctor, because in those contexts, the doctors may not be super experienced. What happened was we did this pilot with, 10, I think it was 2,000 patients. And the way we did it was we said, we're going to take you from the queue and say, do our AI overview so we can check it's okay. And then we've paid for a private doctor that you can just go and see. So you get to jump the queue. You don't have to wait for the whole day. So we thought we get to trial it and also give the patient a benefit. The doctor we hired afterwards said, Randeep, what have you done to these patients? They are the best patients I've ever seen. They come in, they're clear, they're confident, and they can tell me what's wrong with them. And I can have a proper conversation. They don't walk in scared and not talking to me. So we realized that AI system gave the patients reassurance that what was wrong with them was really bad. But the problem was then afterwards, after the 2000 trial, patients would go to the doctors and say, no, I want to speak to the robot. I don't want to speak to a human.
So they thought that the robot had more context and were more...
it listened to them. They wanted to be heard, They felt because there wasn't the hierarchy of this person being senior. They felt heard and understood by a robot more than a human. So sometimes the culture can cause adverse side effects, which is not maybe what we want. So yeah, it's worth thinking about those things as well.
Thank you so much, Randeep, for giving such a amazing cultural context about apps and various countries. Moving with a bit about Satya, you have to think about.
Yes, yes, because I am able to relate this confidence and reassurance with even with how we are interacting with people, right? So Randeep, like most of us are now working remotely, and many young people who've just out of college are also working remotely. It's very difficult for them to now talk to people if they come in person. It's more comfortable to talk to a machine compared to a real human if they come in like in a cafe to drink a coffee or something. So I know it's a very different kind of analog, but I'm able to just connect dots there. Yeah.
But did you see some of these things even in the UK where people were more comfortable talking to machines, or
So what we
was it
realized
more
was,
of a hierarchical?
I think it was different in Rwanda. Nigeria is also different because Nigeria, we didn't have a chatbot per se, but the context of the relationship between a doctor and a patient is slightly different again in Egypt and Nigeria. So, and we're getting to user psychology, maybe it's less relevant for measuring, but in the priceless conversation context, but you have to understand the relationship between your user and the product. And if your product is copying an existing thing, like a doctor, like a technician, like, a driver, what's the context of that thing in the culture that you're working in? So if drivers are considered low status, not very good, your app will have to either work with that or get over that. If doctors are considered the top, you have to understand how your patient or your user is engaging. So what place do they put it? And how do you give them that invisible thing, Satya, you were talking about? So for example, in the context of emerging markets, the thing that I was keen on is, does a user feel comfortable speaking to this? Do they feel they trust it? Do they feel like it is going to reassure them? Because sometimes if you walk out of a really high status, low status conversation, you feel a bit scared and like I didn't get to communicate what I wanted. So we can measure that. Back to what's invisible. If our worry is the user is not going to feel comfortable speaking to a doctor, how can we measure that? After the call's finished, there's a star rating. What do we ask them? Not just, was it a good call? Did you feel heard by the doctor? 1 out of 5. Did you feel reassured that they're going to help you? 1 out of 5. So you can be specific without asking 50 questions. These are the two things that are important in our cultural context, Rwanda versus Nigeria versus the UK. So you can sometimes get the measure, but you've got to think, what are the concerns that the user have? If you come from the user perspective, I believe if a user felt reassured and the user felt they were heard, everything else will be okay. The doctor relationship is going to be the right one. So yeah, I'm not sure if that answers your question, but that was the kind of a way of me measuring the cultural component. I would ask different questions in the UK. Was it quick? Did you get a resolution?
Yeah, that helps a lot.
So Randeep, I think as we are talking more and more to the machines, even in our health concerns as well, one of the biggest issues that are rising is about privacy. It's about data privacy. It's about ethical concerns. How would you address these concerns?
So there's a more philosophical answer than there's a practical answer. So the more philosophical answer is data. The problem isn't people collecting data. The problem is people connecting data. So to explain, in the UK, if you go to a sexual health clinic to maybe look at, you've got an infection or a rash, or maybe you're looking to get an abortion or something, that data is often held in a separate database with a separate clinic. That's how they set it up in the UK. Do you need to do that? Maybe, maybe not, but that was separate. If they connected that then into the main healthcare data, which they are planning on doing, that data gets connected. And you're like, but what if that data was connected to your life insurance or your home insurance or your job prospects? Currently, those data sit in different databases. And I want to connect them because I'm an evil corporation, but it's too hard. Different data sets, it doesn't communicate with each other. The data is messy. It's not easy to connect. Then ChatGPT turns up. One of the big powers of systems like this is getting a data set and reformatting it so that it can communicate to another data set, or sitting in the middle and reading 5 data sets. Also, stuff that, say, a conversation like this, or an audio recording, or a customer service complaint, all of that is qualitative data. It's words, it's videos, it's text. If I can communicate that words into numbers, qualitative data that's messy and noisy and big is now quantitative and can be measured. So the concern for me is not collecting lots of data, it's the data being connected now easily through AI, and the data that was really hard to measure and monitor, which is videos, audios, customer service stuff, now becoming digitized so it can be read. And that connection is what's concerning generally. If you look at healthcare, that's even more concerning because this is the most important. So if suddenly all of your doctor's notes and all of your audio calls with a hospital person could be digitized, is that digitization going to help you or is it going to harm you? If I gave it to the health insurer and they've got a large model that can predict the risk of us having heart disease, that means they can give us higher prices, which means they can predict what might happen in the future more than we can, or charge you higher rates for your car insurance. That's not an outcome that's good for anyone. So for me, it's about the connection. I'll give you one real example. In the COVID-19 app, what it would do is it's different from different parts of the world. The one that we had, the government spent 3 or 4 months building an app that would track your location, exactly where you were, and track who you were with. Now, the Indian app did that weirdly. That's what the Indian app, I believe, was also doing. But the British app, the UK app, that did not work because the people building it worked in government and went, oh, I don't mind telling the government where I am. I don't mind telling the government who I'm with. But most people went, no, that's an overreach. I should not have you tracking where I am and tracking who I speak to.
Yeah.
So the app that I built had privacy. You would tell the app where you were, but that would not communicate anywhere else. It would stay on your app. And the app would know who you were close to, but it would not leave your phone. And if you deleted the app, the data disappeared. It was for your protection, not for the government to know what was going on. And that change was what we needed for the app to be successful. It would not have been successful if it was tracking you. Back to psychology, it could be successful if we gave you power of your data. And so it was only to help you, not to monitor you or track you. So I hope that's how I would think about how it applies in healthcare. Connecting sensitive data to other people who would need it doesn't always help you.
So we've talked a lot about the psychology of how patients work and how psychology of how doctors work in healthcare. And AI is changing a lot of that. What are the other emerging technologies you see, or what are the patterns you see, which will kind of revolutionize healthcare in the next decade?
So
Let's talk about the future.
We'll talk about the future, and I can maybe bring in some of the experience I do on boards as well. So I work, and we'll talk more about that. So I am currently on the board of a large part of the NHS called NHS Business. They do the operational part of the NHS. They've got the largest instance of Oracle in the world. They do the HR system and the payment system for all of the NHS. So that's where they sit. And I've recently been an observer on the board of Aviva, which is an insurance company. They're one of the, I think, the top 15 biggest companies in the UK. So sitting at a board level, I get to see not just what they're doing now, but what they're planning on doing. And what I think is interesting is, of course, everyone's talking about AI. Everyone's talking about that ability to measure, control, run. But the thing that I'm most interested in is this idea of the gatekeeper to technology has disappeared now. If I'm someone who has an idea, I'm a product person, I'm not a developer. If I have an idea of what I want to do, I can build it. I can get ChatGPT to build me at least an MVP or an alpha. And if I can keep iterating that, I can check if this is going to help someone. I can build a therapy app. I can build a website. I've got an idea of something. And I think that breaking out of innovation is quite powerful because the barrier to you building an idea has dropped completely. And I think that means there's going to be lots of crap that gets built, but 1 or 2 interesting ideas will suddenly break out and then they can become full businesses. If I was in Nigeria, Nigeria was amazing. It's the only place in the world where I'm driving around in a car and I see signs for become a product manager, billboard adverts, become a product manager, train here. Because the economy is so distorted there, everyone is trying to hustle and build a career. And they know technology is a thing that's universal. So they can build it in Nigeria and it can ship globally. It's a way of getting money and also getting success, not limited by those around you. And they were doing that before LLMs let you code. So those communities, India, Nigeria, other markets that are emerging, all you need is a laptop. If you have a laptop and you can build a service that looks quite professional, that I think is going to be revolutionary in terms of so many ideas that might serve minorities and different groups can suddenly emerge versus what we have now, which is Facebook or Google deciding what we need and making the same model across the world. It's more of a like 1,000 flowers can bloom and the right ones will then be successful.
So, Randeep, you spoke about tech and products, right? And when I was working on reinforcement learning and different AI tools and teach machines to reason with humans, there's one aspect that has come very significant is as humans, we have at least 19 types of conscious biases. And now, I think you know what the question I'm going to ask you is, as an LGBTQ plus leader, how do you advocate inclusivity and as much as possible removal of biases in tech teams or in tech structures and product designs?
So, great question. I will note the reason the Rwandan patients wanted to use the chatbot is because it was unbiased. They considered that neutral in a way that maybe a doctor wasn't. So AI has the ability, think of the communities that we come from, there's so much bias, caste, but having a doctor or a robot that would help you navigate that, amazing, huge impact. The challenge is building the systems to not have bias. So obviously, I'm a minority in the UK because, yeah, I'm brown. I'm gay. I'm a minority in the UK. I was the first in my family to go to university. Also, you know, I come with different labels. What I realized in building products is if a thing helps one community, it can sometimes accidentally help others. So if I use the example of the COVID-19 app, there's lots of other examples out there, but just that. The app would be that you could use your phone and you could check in to a venue you'd been at during COVID times. And if there was a problem, it would alert you. I wanted the ability to delete the venue that you've been to. Because I thought maybe if you've checked in somewhere, you might want to be able to delete it. They said, we're going to let you delete all your locations. I said, that's not right. If someone checked my phone and saw all my history disappeared, that would look suspicious. Why can't I delete individual locations? For example, I went to a gay bar or an LGBT support room. I checked in and then someone's going to check my phone. I want to delete it. Great. That feature didn't just help LGBT people. Women who are in domestic abuse situations, there was concerns that if their husbands were controlling, they would check where they were. Being able to go to the police station or a women's support center and then delete the location is important. It also helped migrant communities, people who were needed to go somewhere but were worried that someone might check up on them, or they were worried that the police might track their phone and find that they were illegal, refugees. So weirdly, a feature that helped one community helped lots. And that's where I think thinking about inclusive design is important. But when it comes to the teams, you cannot make a change unless you're at the table to make a change. So the reality is you need to have voices that are different at the table to spot those problems. I spotted the problem of not being able to delete all of your location. I said, that feels wrong to me. And if I wasn't at the table to make a decision, that wouldn't be possible. But with AI, the only thing I'll say about AI and inclusive design is AI is built very fast. So what happens is you build for the middle of the bell-shaped curve. You don't take complex people. You're like, I'm going to build a chatbot. Let's just build a simple chatbot that can listen and understand what you're saying. Great. You build it for the average 30-year-old white male. And then you're like, great, I've done it, shipped. Let's move the next feature. Let's do this. But you never go back and fix the edges of that product. Say my mum's got an Indian accent. Does it understand her accent? Does it understand how she uses phrases which might be different from standard English? Probably not, because they built it for the standard white English person, then moved on to the next feature. What they need to do is go, we've built this MVP, the MVP team move on to the next feature, another team inherit the MVP and build it out to make sure it helps as many people. Because in most systems, if you daisy chain 3 or 4 different AI systems, in the simple example, in Rwanda, I go up to a robot and I talk to it about my problems, it answers me, and it helps me decide where I go in the queue. It decides where I go in the queue. Do I see a doctor, a nurse, or no one? In that system, I need to have high literacy because it's talking to me about words that I might not understand. I might have quite basic information. I might have an accent. I might have a different concept of medical care. So those 3 or 4 systems, when they daisy chain together, if you only work on the middle of each, you end up removing 30, 40, 50% of the population because they will never get from the beginning to the end. So I think it's important being an LGBT leader and a minority leader, but also those things that you bring to the table help everyone. And if you keep thinking about that experience, you can make sure that it helps more than you think in a product.
Thank you so much, Randeep. Yeah. Is one question that we ask most of our guests is about the effect of the technology in short term and long-term sustenance of the same, let's say in health tech? How will the technology affect the short-term goals or impacts versus the long-term goals?
I think you might have to rephrase that question. So maybe try that again, because I'm not sure I fully understand, and I'm conscious of time as well. I'm gonna have to leave in about 3 or 4 minutes, but
I
yes.
think then we can skip the question in that way. So I think this is very important. So this question I'll ask: how can people, or how can our listeners reach out to you?
So typically, I am on LinkedIn. So if you have a specific question, I mean, obviously it's a hard medium because you have I think I've got 150 people who've asked to connect with me, and I can't always message all of them. But obviously they can reach out to you, and I'm happy to answer questions if it's useful. But obviously I'm currently in the space of looking for product roles and kind of advising and consulting roles. If anybody's interested, feel free to reach out and make sure the message is clear that it's based on the Priceless Conversation podcast and it's about a question or a job opportunity. Please do let me know. But yeah, for me, it's sort of useful because I do a lot of work in healthcare. So if someone's got a question that I can help with, I'm happy to do that. It's harder to just go, I've got a general question about how to get into healthcare, because that's not something I'm always able to support, because I do get quite a lot of that. So I do podcasts like this to help give that information in a mass way without having to speak to hundreds of individual people. But there's other podcasts. If you want to get into health tech, I was featured on, there is a podcast called I think it's called the Health Tech Podcast, where there was a whole season about how to get into healthcare and health tech specifically. It's the Health Tech Podcast, and I was featured on that about the specific question of how to get into health tech. And I've done Mind the Product talks, and so on my LinkedIn there's some videos to that stuff as well.
Yeah, well, I was going to say that your Mind the Product talks, especially about heroes and villains of product management, that's very well received in the product world, and one of the more entertaining and useful product talks we have.
Thank you. That was a interesting one, which is where if you try and advocate for change, often you become the villain in the room. Yeah. And the reality is sometimes you might need to lean into that. So there's something interesting, but like I said, I think that's but you can probably link to it, Amit, in the show notes if you want to kind of link to that talk if people are interested.
Awesome. So that's the wrap on this episode of Priceless Conversations. Thank you.
It has been a pleasure having you, Randeep. Thank you so much. Thank you for sharing your story.
Thank you both so much. I will speak to you all soon.